preoperative diagnosis is right knee medial and lateral meniscal tears, right knee plica syndrome, right knee Hoffa syndrome, right knee synovitis. Postoperative diagnosis was right knee medial and lateral bucket handle meniscal cartilage tears, Hoffa syndrome, synovitis, and plica syndrome.
When you look at a meniscus, just the outer third or outer 20% has blood supply. And then as you go more in, it's avascular. So if you get a tear out in this area, we call that the red on red region because it's vascular and you can repair it. If it's torn where the vascular part meets the avascular part, we call that red on white. And then if it's torn in the avascular area, we call that white on white. So that is just totally trash. You like running and you plant and you pivot and you get an axial load, the thigh bone compresses against the shin bone, you get a shearing action and you just shear the meniscus up. That's the whole meniscus. That is not going out.
Well, like when you lean, feel like it's about to bubble.
Yeah. So this cat is a candidate for a meniscal transplant. So we got to go back and review the MRI. By day, us too.
Indication for the operation: a 26-year-old male sustained an injury to his right knee, resulting in bucket-handled medial and lateral meniscal tears. Treatment options were discussed with the patient, and after a long discussion of the risks and benefits of both operative and non-operative care, the patient elected to proceed with surgery. Brief description of the operation: the patient was identified by name, given preoperative antibiotics, taken in the operating room, general anesthesia was administered. The right lower extremity was placed on an arthroscopic leg holder and was poked and draped in standard sterile fashion. The knee joint was injected with 10 cc's of 0.25% marking with epinephrine. A standard inferior medial and inferior lateral arthroscopic portals were established. Diagnostic arthroscopies performed.
So having the rim is better than nothing. Barrel, right? So you get the wooden planks that make the barrel and you got the metal boots. So the more pressure you put on the inside pushing out, the more that hoop stress pushes back in, right? So that's the way a meniscus works, is it's got longitudinal collagen fibers that act like a hoop stress, so that when the thigh bone pushes down, it evenly distributes force. If you get a tear that just goes straight back, I mean, it's done. You know what I mean? You don't have to lose the whole meniscus as long as you disrupt the longitudinal fibers. Then the meniscus loses its function.
Procedure performed was right knee arthroscopy with partial medial meniscectomy, partial lateral meniscectomy, plica resection, resection of Hoffa's fat pad, partial synovectomy, and platelet-rich plasma injection. Anesthesia was general. Blood loss minimal, complications none. Synovitis in the suprapatellar pouch in the medial and lateral gutters was debrided extensively using a shaver and a radiofrequency probe. He had no conomalacia on the undersurface of the patella or in the intertrochlear groove. He had fibrotic retropatellar fat pads consistent with Hoffa syndrome, and that diseased tissue was removed using a shaver and a radiofrequency probe. His plica was removed using a shaver and a radiofrequency probe. I then turned my attention to the medial compartment, where he's known to have a bucket-handled medial meniscal tear involving 90% of the inner margin of the entire medial meniscus. The bucket-handled portion was so damaged and macerated that it was irreparable. I then used a basket and a shaver to perform a partial medial meniscectomy using standard technique. He otherwise had no conomalacia on the medial femoral condyle or the medial tibial plateau. The ACL and the PCL were intact. He also had a bucket-handled lateral meniscal tear involving approximately 20% to 30% of the inner margin of the lateral meniscus, and that was debrided back to stable tissue using a basket and a shaver. The popliteus tendon was intact. The popliteus hiatus was intact. There was no significant conomalacia on the lateral femoral condyle or the lateral tibial plateau. At that point, the instruments were removed. The portal sites were closed using 2 monochrome in a subcuticular fashion. Stereostrips were applied. The knee joint was injected with 5 cc's of platelet-rich plasma obtained from the patient prior to the start of the case. A sterile injection was applied. The patient was awakened and transported to the PAC in stable condition.